Good afternoon. Welcome to this session. And come, hi. Okay, the first speaker is Dr. Subhashini, and let's hear her out on Fingertip. Subhashini, please.
Good afternoon, everyone. So we are starting the fingertip session. I am myself Dr. Subhashini, working as Associate Professor in the Department of Hand Surgery. So this is a 98-year-old flap. This was described by 1926 by Gatewood. He has no first name, and for that he rose into more fame than describing many procedures. He described it as a random pattern flap raised from the thenar eminence, and it was a radially based flap. It was close to the MCP region of the thumb. Adrian Flat further popularized flap by two papers published in 1955 and 57. Here he describes the flap as a proximally based flap. He discussed in detail in the paper published in 57 about the need of the flap and how to avoid the complications, namely first web difficulty, scar deformity, and PIP joint contracture. He advised to follow 3 rules which hold good even today. The length should not be more than twice of the width, and he advises us to take not necessarily full thickness of the fat. We can take 2/3 of the thickness and leave behind the 1/3 to have a suitable bed to accept a graft if needed. And no attempt should be made to close fully the 2 sides of the defect. Various purchase should be made in the radial and ulnar side. Beasley and later Rinker popularized his concept, where it was raised as a radially based flap with one border of the flap positioned in the metacarpophalangeal flexion crease of the thumb, and the leading edge was made into a V or W based on the need. That helped in better closure of the donor area. The surgery can be performed under local, regional, or general anesthesia. Patient, when performed under local, doesn't even need hospitalization, can be sent as OPD basis. Tourniquet is must. Finger tourniquet and local anesthesia to the thenar region also can be done. Loop magnification is needed. The site of the flap, either it is taken at the height of the hypothenar prominence or close to the MCP region based on the lie of the defect. The advice given by Adrian Flat is to flex the metacarpophalangeal joint maximally and to keep PIP joint flexion at 90 degree, and DIP flexion should be maintained at 0 degree. Post-operative protocol, whether POP splint is needed or not, should be decided based on the patient. If the patient is not compliant, it is better to have a dorsal POP and start mobilizing within the POP. If the patient is compliant, it can be managed without POP but with strict hand elevation. And a division is done by 2 weeks. So this is after raising the flap, we are checking the flap viability. Here we can see there is the thenar muscles are seen. This defect can be closed primarily. This is the regular thenar flap done and post division. Here we can see that the terminal phalanx bone is exposed. So a nail bed graft was harvested, partial thickness nail bed graft was harvested from the great toe and fixed to the dorsum defect nail bed, and then a thenar flap was done. This is the post-operative picture. There was no PIP joint stiffness or scar hypertrophy in this patient. And here in this patient, we have done the thenar flap with eponychial recession so that we can have a nail length increase by 3 to 4 millimeter. This is the late follow-up of the patient. And again, thenar flap, I'm not touching much because we have a separate topic, can be done along with the graft reposition of flap. And when there is a defect in olar and dorsal side, it is better to raise it as a H-shaped flap and close the defect can be closed primarily. This flap will not tolerate the bending of the flap. Folding of the thenar flap is not advisable. And once we give insert to the flap, it is preferable to remove the tourniquet and check for the viability. Sometimes a single stitch can be tight and causing the decrease in blood flow to the flap. So modifications, it can be raised distally, proximally, radially or ulnar based. Lee Dillon has described about the distally based flap, where the leading edge will go and get insert in the proximal edge of the flap. So the fingertip area will be open. He feels this type of flap gives a better flap result. And now recently there is a rampant of free flap, of thenar flap. It can be done with graft reposition or a non-vascularized nail bed graft or with aponychial recession. Nowadays we close the donor site primarily as long as the defect is very big. But when Gatewood described, he has advised strictly not to close the defect primarily and to apply SSG. So in a 150 cases series by Beasley, they have reported there was no flap loss, but it is not the case always. Improper positioning might cause loss of the flap. Sometimes the epidermis part alone might become blackened in color. Most of the time we can salvage part of the flap. It gives good aesthetic outcome when compared to the other flaps. The Ringer et al. Studied in detail and found that the postoperative decrease in range of movement was only 3 degree for the PIP joint, 6 degree for MCP joint, and 13 degree for the DIP joint. The increase in loss of ROM of DIP joint was attributed to the loss of the height of the terminal phalanx in many cases due to amputation. The mean static 2-point diameter was 6.8 millimeter, and the moving 2-point diameter discrimination was 5.5 millimeter. This discrimination was less than the normal sensation of the finger, but it gives the protective sensation to the patient. Thank you.
Any questions? You want to add anything about the digital nerves to the thumb? How you protect the
Yes,
nerve?
sir. While when we are taking the full thickness fat of the flap, we have to make sure that we are not injuring the digital nerve of the thumb. We have to look for it.
When you are approximating and closing the wound, you seem to
Have a
gather a
bulge.
dog ear.
Yes,
So
yes,
do
sir.
you take one part of the dog ear and reflect it to cover the
I
flap?
correct the dog ear primarily, sir, because the dog ear doesn't go away.
Thank you. Any questions for? Yeah, please. Shashi.
Yes, sir.
In the dominant hand, if you're taking a thinner flap, does the patient complain about the grip problem later on, or they're all very fine with that?
I have not seen, I am practicing for almost 11 years. I would have done around 60 to 70 thenar flaps. Sir. I have not had a patient who is complaining of hypertrophy scar or hypersensation or decrease in power or grip strength.
I think that is the major problem with the thinner flap. And I personally am very much against anybody taking a flap from the hand unless until it is a neurovascular
Island flap.
Okay, if it is an islanded flap, and you have got so many options for fingertip. Actually, we do not need to take the thinner flap. It should be left only for the primary surgeon somewhere. And this thing, once a person comes to a center, thinner flap is really not the option.
Thank you, Doctor.
Thank you, sir.
We'll go to the next topic. I call Dr. Vijay.
Good afternoon. Today's talk is 50 cases of JRF hard learned lesson from the field, 12-year experience. So we'll start with the archive. The first patient I treated was 2012. I was not a microvascular surgeon that time. So patient told me I want a nail. So I said, let me try. So I put it back like as a JRF, and this was the result. That result encouraged me to do a further study and design this technique. So I gathered 6 cases and I presented in ISKCON 2014 as a 6-case report with chairman, well-known face of the hand surgery in front of him. First publication was 2015, 6 cases same. Type Allen type 4 amputation present to us in different way, different manner. expectation of patient was, first thing is, any fingertip injury, patient doesn't ask about sensation, nothing. They ask only, what about my nail? Will we grow or not? So first is nail, then finger length, then cosmosis, sensation, return to work. So why nail is important? The nail is important for cosmosis, nail biting when you are nervous, self-defense for female, picking up a small object, scratch, and even in history, Picasso kept his long little finger nail for mixing the paint. So nail is very important to everybody. So coming to the Allen classification, he has classified in 1980. We are interested in type 4 amputation, where the 2/3 loss of distal phalanx and pulp bed through lunula. Now the problem is that if you see, he says that through lunula, and when you put a K-wire on the lunula, where it ends. And in diagram, his original paper, he has shown down. So that's why his result, 3rd and 4th, was horrible, comparing 1st and 2nd. So I have modified this. So in my classification, distal to the lunula is a non-GRF zone where it comes on 1, 2, 3, where the more than 50% bone support is there. There's no required of bone to attach. But if it is proximal to the lunula up to the eponychium, we need a support of bone, and which falls into a type 4 amputation. I call it as GRF zone. What is graft deposition flap? It is a reattachment of bone and free nail bed separately covered with a local flap. Principle of GRF, increase the area of contact with a vascular bed is known to increase the survival rate. This is a schematic diagram, and I'm not going to show you the technique. It is out on the internet. 50 fingertip amputations, retrospective analysis 2010 to 2024, 6 female, 44 were male. Average age was 32. Right side dominance was more. Middle finger is more commonly affected. 35 crush amputation, 18 were domestic. 45 acute, 5 delayed presentation. Transverse amputation was common. All patients brought amputated fingertip. Results, there were various scoring system outcut questionnaire to assess the hand injury outcome score, but fingertip injury doesn't have a proper score. So, me and my colleague, Dr. Terence, I have published this fingertip injury assessment score, which is very easy. It is for points, nail, finger length, pulp, bone, cosmosis, sensation, pain, range of motion, grip strength, and return of work. These are the common things. We grade it, and we interpreted this score like excellent, 12 or less than 12, good 13 to 18, poor is about 24. So I interpreted this score with my study. I found 63% is excellent, 12% good, fair 6%, poor 18%. So I have classified again type 4 amputation into the 4 type. The type for A at the level of lunula, between lunula and the eponychium. B, 4C at the level of eponychium, and 4D is the proximal to eponychium. Why? I will show you. This is the case number 1, type A amputation. It's lunula. It's got excellent result. Score. Type B, between the eponychium and the lunula, it gets good result. Type 4C, through the eponychium, results are fair. And if it's type 4D, proximal to eponychium, results are bad. So this, upon this level, you can judge which has to be put back and tell the patient that this level you can get good nail, this level nail will not grow, but you will get something to pinch. So results from A to D gets poor. Late presentation in type 4 amputation. This patient came with this fingertip at 6 weeks, and because he wants a fingernail. So I told him why you have kept it. So that he told me that I think it will be useful in future. So that I kept it in the pocket. That was the story. So what I do, I debride it. The bone was healthy. It was not necrose at all. I put it back. I do the nail bed grafting from the middle finger, and I fix it and covered with a cross finger flap. This is the 5-year result. He's got good nail, Even we do a CT scan, there is a healing of the bone. Again, 15 days old, reattachment as a composite graft. We did JRF, bone work graft was used by that finger only. We harvested the middle finger nail bed, and this is 2-year result. Toe amputation. We have did JRF, only one patient. So what is the criticism on JRF? How free nail bed graft, bone graft survives as it is a composite graft. So this is the theory. Separation of the bone and the nail bed as a free graft increase surface area. Drilling of the bone in the procedure increase the perfusion to the nail bed from the flap by plasmatic imbibition. Meshing the nail bed again increase the surface area to take up the nail bed graft, and reposition of the nail plate in the nail fold avoids the necrosis of the nail bed by air drying. So to prove this theory, we did a vascular angiography, and if you see, there is a vessels which are giving nourishment to this bone, thinner flap, JRF. Biopsy was done after 1.5 months. And this is the histology of nail bed. You can see this common stratified epithelium. We do a bone histology. There is a new bone. There is a no dead bone. So in our type 4 amputation, straightforward algorithm, replantation, successful, normal finger. Failure, go for JRF. Other option, you have got shortening flap closure, unfavorable result. These are the citations. In conclusion, JRF has proven to be a simple, reliable procedure. It does not require advanced skill and utilizes methodology that should be within a skill set of most of the well-trained resident fellow hand surgeon and orthopedic surgeon. JRF is recommended as a technique for Allen type 4 amputation, emphasizes its variable role alternate to other reconstructive position. So this is my thought that imagination is more important than knowledge. Imagination is the language of our soul. Pay attention to your imagination. It creates a wonder. Thank you very much.
Thank you, Vijay sir. Any questions? I have a question, sir.
Yes, sir.
How do you counsel the patient, sir? Do you always give them how prognosis of the procedure? How do you counsel the patient when the patient asks?
See, if patient comes to me and there is within a level of that amputation, I said that you will get a good nail. I will not assure him, but it will be good nail, good function, good length. That's it.
Is there any point of time that it didn't work for any patient?
Yes, I shown in the classification only. The types C and D, this is disease zone. But A and B, you gives good result.
So when it is type D, mostly will be doing thinner or cross finger flap, sir?
It depends on the surface area. If it is a volar oblique fracture, I will go for a cross finger flap. It's a transverse fracture, a transverse amputation, I go for thinner flap. Because cross finger flap, you have got a very good surface to cover. Thinner flap, it doesn't go much volarly. And I always prefer thinner flap in this area, radial side. So that question was there where there is a hypersensitivity. Because when we grip, it doesn't come into contact with this object. So it is free from the contact. So always I do the wrinkles modification, not in the palm here, radial side. So it gets away from the contact area.
So when the graft is not taking, will you do a secondary procedure or allow it to heal secondarily?
See, it depends on if it is a nail bed necrosis. I do a nail bed graft. Okay, and third thing is that when we do the dressing, don't open for 3 weeks. Keep it like this only. Because every day you open the dressing, you give contact air to the nail bed, and usually what human tendency is that to see the nail bed while lifting up the nail. It is okay, it's a necrosis, and that is causing air dye necrosis. So in video I have shown that you have to take a stitch to the nail to the flap so that it will close the gap between the nail bed and prevents the air dry necrosis.
Thank you, sir.
Thank you.
Sir, I have a question, sir.
Yes.
I am Dr. Prakash. I am from Bhubaneswar, Odisha. Very nice presentation.
Thank you, sir.
I have some doubt that I need your clarification. What's the maximum age that you can rely? Second, What should be the minimum or maximum time limit since injury? And what amount of defatting you need to do before you are going to reposition that graft?
Okay. So first question, I did 70-year-old male. I got a bad result because he was a smoker. Okay, it was in type D, poor result. Second question, what is your second question?
Time since injury.
Usually within a 24 hours you can safely put back nail bed, provided it should be a cold storage. How you amputated finger stored, same way you can, after 24 hours you can put back that nail bed again. If it is not stored, minimum 4 to 5 hours.
What amount of defatting you need to do before no.
When you separate the nail bed and bone, I do thorough debridement because I don't leave a single tissue on the bone because it will eat up the blood supply. I want to take a blood supply only to the bone, not in between that. So I see under loop, I can remove all the periosteum also. I will remove. I will not put the periosteum also. And third?
These three only.
Thank you.
Thank you, sir. Thank you, sir.
Thank
I
you.
request Dr. Chaitanya.
So you have tried 4D and all. So how proximal have you tried? Is still proximal?
No,
Not
because I am not a replant surgeon, so I don't tried it.
No, not replant, but anyway,
No.
You want?
No, I have tried, but I assure that there will be no nail. It will act as an osteocutaneous flap.
Okay, so no this onychium is not there, so you don't try that.
Thank you, sir.
Thank you.
I request Dr. Chaitanya. He will be talking about oblique triangular flap.
Good afternoon, everyone. I would like to thank the organizers and the chairpersons, especially Dr. Pankaj and Dr. Subhashini, who have been in touch with the presenters so that the topics don't overlap and the audience get to know something which is different from each session, each presenter. I'll be talking on oblique triangular flap. Again, whether I'll be able to tell you how to master it will be known after I present. I have no disclosures. Now, as the previous presenters have already emphasized, fingertip is highly specialized tissue, which are both functional and aesthetically irreplaceable. Reimplantation remains gold standard, with recent current trends up to 86% survival rates. But in very distal amputations, microsurgical anastomosis can be extremely difficult or unfeasible. Now there are various classifications for fingertip. There are various options. But what is very important is we need to counsel the patient. We need to talk with him as to how much will be the recovery time, what are the options, and what suits considering his circumstances. Again, this because many of my patients back in UAE are blue-collar workers who probably might not want something which is very complex, which will make them to stay in a hospital or with a dressing for 3 or 4 weeks' time. And they just probably want a stump closure wherein they get back to work in a week. Now coming to oblique triangular flap, which is very suitable for irregular amputations. Now as described by the master way back in 1980, by Dr. Venkateswamy. He made a triangular flap which was 2.5 times the width of the defect, and then the apex was proximal, dissected it proximally so that you mobilize this skin flap further to cover the fingertip. The advantages being it is stable and sensate, and depending on how much you dissect proximally, you can advance it up to 15 millimeters or even more. Now, how much progressively we can dissect proximally? Again, we have 2 cadaver studies which show that if we dissect the neurovascular pedicle up to PIP, it's about 8 millimeters. Up to MCP crease, it's about 12 millimeters. And if you divide the adjacent digital artery, it goes up to 15. And if you go to the superficial arch, you can go up to 18 millimeters. roughly 2.6 millimeters for every 10 millimeters of pedicle mobilization. Now, how we try to get better at doing an oblique triangular flap? Personally, what I prefer to do is include at least one volar vein. Before you insert, make sure the flap is bleeding nicely and there is absolute hemostasis in the field. Dissect the pedicle proximally so that you don't do a closure in tension or you keep the PIP or DIP joint flexed. So this is the description. As you all know, we do the dissection 2.5 times of the width of the defect, go all the way to the MCP crease. We followed up about 22 fingertips within a 6-month duration, which were followed up for more than 12 months. Most of them were males. Flap advancement was about 11 millimeters on an average. The sensation recovered back to normal in about 6 weeks of surgery. Only 2 patients were not satisfied, where we ended up with some secondary defect which needed skin graft, which caused some cosmesis. Again, if you look at the average loss of working days, it was about 4 weeks. Some illustrations. This was one fingertip which was transverse. Again, if you look at the picture on the right, it's important that you include a volar vein. This is the follow-up at 8 months, wherein there is no contracture at the PIP or DIP joint, a very well settled flap, and a nail which is almost normal. This is another case wherein the advancement was good enough to cover the fingertip, but there were some raw areas which needed skin graft. Again, very well settled, but this patient had concern because the area where we put skin graft, there is some mismatch in color. This is another case. Again, the flap was done only for the index finger, settled very nicely, and mobilized within about 1 or 2 weeks. And this is how it looks. Complications which can arise in this flap are reduced vascularity because of inadequate mobilization, or you suture the flap in too much tension. PIP joint contractures have again been described, but I believe this can be avoided if you mobilize the flap well, and when you insert it in full finger extension. Sensory disturbance is again noted if you mobilize more than 12 millimeters. Now, in our center, we are extending the use of this oblique triangular flap for correction of hook nail deformities in combination with GRF, especially in pediatric patients, what Dr. Vijay just described, and for providing sensate cover for fingertip amputations at various levels without any further bone shortening. This was for hook nail, where you can see there is severe beaking of the nail. We took a oblique triangular flap. We did a small osteotomy on the phalanx which was present, extended the nail bed, and used this to cover the pulp. Unfortunately, this patient has not followed up, but we try to do more of these. This is another case where you have amputation at the DIP joint level. Generally, these, when you do stump closure, you invariably tend to shorten the bone, which will further shorten the finger. Even in these cases, if you just debride the cartilage, get a small oblique neurovascular flap, you can cover the tip without any further shortening. Take-home message is it's a very versatile flap, especially for irregular fingertip amputations. It's very important that whenever you suture it into the defect, you have a tensionless suture closure. It provides a reliable sensate cover, and it also matches contour. Thank you.
Any questions?
Dr. Purushothaman, and I worked with the master, still working with him for the past 3 decades. And of course, there are many ways of skinning a cat. When we do triangular flap, the other side neurovascular bundle, we leave it in the bed, that is with the finger.
Correct.
It doesn't come with the flap. And we don't do it for more of volar loss. In some of your cases, there was more volar loss.
We had to advance a bit further.
Yeah, we do it only for transverse amputations. just to clarify a few things.
Thank you.
There are no more questions. We thank you very much. We
Thank you.
invite the next speaker. I can't see.
Call upon Dr. Lee. Yeah. She'll be talking on cross-finger flap, reliable solution for complex defects.
Hi, thank you. Good afternoon, everyone. Very happy to be here. Okay, so today I'm going to speak about cross-finger flaps. I think everyone in this room is very familiar with this flap. So with just 8 minutes, I've decided to focus on at least how I personally optimize outcomes for my patients with this flap. So a brief history, this cross-finger flap is actually 74 years old this year. It was originally described by Gurdin and Pangman in 1950, and it was described for volar unfavorable fingertip injuries. It was originally described as a random pattern flap, but we now know that it is vascularized by the C vessels that, okay, you can't see my mouse, never mind. The dorsal vessels that branch out from the digital arteries. So for a classic cross-finger flap, what we do is we take a rectangular flap from the dorsum of a segment of the adjacent digit and then sling it over and flip it over to cover the volar unfavorable pulp loss amputation. The flap is then divided at 2 to 3 weeks, and then this is the final outcome of my patient, showing a good healing and very normal range of motion. Now, this flap can also be done in a reverse manner, and this is an example of the reverse cross-finger flap. What we do is we take subdermal elevation of the skin flap, then an adipose layer, adipose fascial layer for the actual cross-finger flap to cover the dorsal defect of the digit, and then anchor the adipofascial flap over the dorsum of the digit, and then cover the flap with a free full-thickness skin graft. Thereafter, we flip back the subdermal elevation of the skin flap to cover the digit, and this is the outcome after division. Now, this flap can also be done as an extended cross-finger flap, whereby we cross the joint creases. So this is a case of a very unfortunate domestic helper whose hand was actually crushed by a sugarcane press injury. So essentially, all her fingers went into the sugarcane press, but the main injury was in the index finger as well as the ring finger. So we'll focus on the index finger here. You can see there's loss of almost, I would say, 90% of the volar surface of the digit. So a large cross-finger flap was taken from the middle finger, even though that skin was also involved in the roller press injury. It was deemed to be sufficiently vascularized, and so we went ahead with this. The other thing was because she could not afford the free flap surgery or could not afford to stay in hospital for a prolonged period of time. That's why we chose the extended cross-finger flap for her as well. So this was taken across the PIPJ skin crease, and this is the final outcome after division, the early final outcome after division, showing a good take of the extended cross-finger flap. Her healing was complicated by a little bit of loss of the full-thickness skin graft that fully healed eventually by secondary intention. In her case, she got about 50% range of motion eventually, but this was also contributed by the crushing nature of the injury. So how can we get a good result for cross-finger flaps? Number one, patient selection and counseling is very, very important. It's important to go through with them what to expect and focus on frequent rehabilitation and therapy measures. So it's also important to select the defect. As mentioned, close follow-up is important, and we should not rush to divide the flap. I know there are people who divide the flap at about 2 weeks, but personally I divide them all at 3 weeks. And my personal opinion is to avoid the cross-finger flap for any middle finger defects because it requires you to flex the middle finger by a lot more, and it predisposes the patient to developing stiffness of the PIPJ. So this is what I do. I'll go through them in detail, step by step. But importantly to mention, I actually do not innovate these flaps because they tend to have a decent sensory outcome on their own. So firstly, the cross-finger flap is a rare instance where we actually match the defect to the flap rather than vice versa, which is commonly done, right? This means that we may need to enlarge the defect size to allow an aesthetically acceptable outcome. And this goes in line with the concept of the functional aesthetic units or subunits of the hand. So it's important to note that both the pulp as well as the donor side of the cross-finger flap are both considered an aesthetic functional subunit of the hand. So if we were to just take half of the width of the dorsum of the finger, the aesthetic outcome will actually be uglier than taking the entire width of the dorsal aspect of the finger. Yeah, this is just some case illustrations to show the coverage of the functional aesthetics of the hand. Next, we go into the design and extent of the flap. Okay, so the lateral extent of the flap can be up to the mid-lateral line, just dorsal to the neurovascular bundle on the other side. Taking the full width of the flap, number one, it encompasses the functional subunit. It also allows for further reach of the flap, so you can actually go all the way to the far corner of the digit. For example, in the left side picture that you can see, the cross-finger flap was used to cover the far side of the index finger. This also allows for better contouring because you have more flap availability. And as mentioned earlier, it is okay to cross joint creases. Now, the plane of elevation is, of course, between the subcutaneous tissue as well as the peritoneum. It is absolutely important that we have zero disruption of the peritoneum to allow good take of the full-thickness skin graft later on. Now we move on to insetting and contouring. This is important for attaining a nice rounded pulp contour. So what I do is how exactly do we inset this, right? I think it's not commonly described in any papers, but all these I learned from my seniors. So what we do is we first inset the spine of the book, where you can see the yellow circles. That's the first stitch that I do. Whether it's a reverse cross finger or a regular classic cross finger, this is the same thing. And then after that, we flip the hand over or not, and then we go on to insert the proximal most aspect of the cross-finger flap. This enables you to know how far a reach you can obtain with the flap. Next, then I do the lateral most aspect, and subsequently, finally, I insert the apex of the flap to contour the pulp properly. Now, a small point about the full-thickness skin graft that we use to cover the donor side or the flap. I used to fenestrate them earlier on, but I realized that actually they do not heal very well with fenestrations because, not that they don't heal well, but they heal too well sometimes. So some of my patients actually develop painful hypertrophic scars through the fenestration points. So what I do now is I just do this. I just lay on the full-thickness skin graft with no fenestrations. Of course, they have to be adequately tensioned. And an important point to note is that the problem of full-thickness skin graft take always happens in the valley between the flap, in the valley where the digit contacts the donor side. So what I do is that I take a roll of Gelonet or any form of tool gras dressing, I roll it up into a cigarette rather, put it there and ensure that the cigarette layer is flush with the level of the full-thickness skin graft. Thereafter, I do a tie over, and then the tie over is usually kept for about 1 to 2 weeks before I remove it, and then I start the patient on regular therapy and divide the flap. Next, we move on to the division. The division of the flap is done at 3 weeks personally for me. What I do is I just divide it down the middle, but importantly, after that, I do a wedge incision, where you can see the black cross lines here, a wedge incision here, so that when we stitch the flap down, there's no overlap of edges. Now, this is a quick example of a patient, another elderly lady with sugarcane roller injury. Reverse cross-finger flap was done. You can see that the edges are nicely matched there. Okay, now can I have 1 more minute? Okay, thank you. Okay, so the cross-finger flap has some variants. It can be done as an innervated flap. It can also be a venous flow-through flap that is useful in the setting of the need for establishment of venous flow in replants with dorsal skin defects. Now, it has some problems that I will go through here. It is a 2-stage procedure. It actually violates an uninjured adjacent digit, but with good surgical technique and good post-op rehabilitation, patients actually get very normal function despite using an uninfected digit. It covers the defect with non-glabrous skin. That's also a drawback. It can also be hair-bearing, and color mismatch is an issue in darker-skinned individuals. As for sensation, we realized that actually, even though the flap is not routinely innervated, patients actually develop very good protective sensation, if not normal sensation, compared to other digits. So personally, I've stopped it. Rather, I never innervated these flaps to begin with. This is a study done by Dr. Lim and Dr. Chong. published in Hand Clinic, showing that most patients actually have decent range of motion as well as decent sensation. Okay, that's the end of my talk. Thank you very much.
Okay, thank you, Dr. Lee. Any questions?
Thank you.
Yeah, thank you. Call upon the next speaker, Dr. Jin. She'll be talking on homodigital neurovascular island flap.
Hi, good afternoon, everyone. So I'm very honored to be here today to give you this talk on homodigital neurovascular island flap. Skin and soft tissue defects after fingertip injuries and infections are common problems. A stable, mobile, and Okay, a stable, mobile, and sensate fingertip is important for the overall function of the hand. So the nail is also a prominent feature of the finger. It fulfills both an aesthetic function and a functional role, allowing increased sensory perception in the pad of the finger and accurate picking up of objects. So when considering whether to reconstruct a fingertip amputation, we need to take into account the patient factors, injury factors, and surgeon factors. And I think the most important is the patient's choice and the technical expertise of the surgeon. So when choosing the procedure, we need to consider the size of the defect and the availability of the amputated part. In small volar favorable defect, we can treat it either by letting it heal by secondary intention or use a VY advancement flap. However, for slightly larger defects like a volar neutral defect, my preference is to resurface using a neurovascular island flap from the same digit. So the flap is raised as a triangular shaped flap on one of the digital neurovascular bundle of the digit and advanced to cover the defect. The donor side is usually closed primarily. So there's subtle differences between a homodigital NVI and a Venkata Swami flap. So in this flap, we dissect out the neurovascular bundle clearly. So this flap covers the defect in two ways. First, by transposition of the flap to the midline, and the second way, by advancement of the flap along the lateral aspect of the digit. Some technical tips for everyone. First, the retrotendinous branches must be ligated carefully to avoid troublesome bleeding after you release the tourniquet. Ligating dorsal skin branch at the base of the digit usually gives significant advancement. If we need more advancement, we need to ligate branch of common digital artery after the MCPJ. And we should try to preserve adipose tissue surrounding the neurovascular pedicle. So in my own cadaveric study, I found that the advancement is 8 mm when we dissect until the PIP crease, 12 mm when done till the palmodigital crease, and if we divide the adjacent digital artery, it will give about 3 mm more advancement, and then 3 mm more when we dissect all the way to the arch. In a review of the literature, I have found that this flap was reported to be able to advance to up to 22 mm. However, authors have not mentioned how this advancement was measured, and it is possible that they have measured relative advancement. And some of these papers where they report a very lengthy advancement also stated that some flexion of the finger was required. There's one paper that finds that there is higher prevalence of dysesthesia if advancement is more than 12 mm, and that's also what I believe in. So there's some variations in flap design. The standard design is an oblique triangular flap. I've also seen papers describing circular or ovoid island flaps. But please note that in this paper, the authors have used this flap to cover volar unfavorable defects, which I haven't had good experience with, because I find that they usually do not advance so far. And you can see here that the neurovascular bundles looks a bit stretched, and there is some flexion of the digits that is required here. This is a flap designed by Prof. Teo from Singapore. We call it the spiral flap, and this flap is advanced in an oblique spiral fashion around the digit. The pulp switch flap is a design first proposed by Fouché in 1989. The purposes of this flap is to provide sensate skin to critical sensing areas in the digit or thumb that has lost its sensation. This is a case contributed by Dr. Tina Lee. In this patient, the flap was used to resurface defects that is at the volar aspect of the DIPJ, so it's not at the fingertip. And we can also use this technique if we have a concurrent nerve or vessel defect that we need to breach. This is a study done in my center. Out of 233 cases of MVI flaps in this series, there is a reoperation rate of 3.8%, which is actually quite low. The majority of reoperation is actually due to inadequate coverage of the fingertip. So I will usually only use this flap in a volar neutral defect and nothing bigger. In a slightly larger defect, I may shorten the fingertip so that the homodigital NVI can cover the defect adequately. Looking at the results of this flap, we can see that most can achieve normal sensation and that the flap failure rates are low. However, the range of motion varies between different series. Okay, and in my experience, patients with skin that is soft and thin, and usually they have excellent outcomes in terms of range of motion, but the workers who have very thick dermis usually get more stiffness. So this is an NVI flap done for oblique defect at the fingertip. And we can see here that the patient achieved really good results with normal sensation of the tip at 3 months post-op. I surveyed my colleagues yesterday night, and we all agree that we get good motion for about 80% of the patients when we do this flap. A quick note on aponuchal recession. I personally like this procedure because in patients with tip amputation and a very short remnant nail, this is a good option to do. It involves excision of a crescent shape or rectangular shaped area over the aponechium, and then subsequently closure. So what we do here is to expose most of the nail bed and the nail plate. So we can usually get about 2 to 3 mm more exposed nail bed, and this gives a aesthetically pleasing nail in terms of the length. In conclusion, we should address both pulp and nail deficiencies in order to reconstruct an aesthetically pleasing fingertip. Indications for flap coverage must be correct in order to minimize complications and maximize the outcomes. This flap is not for large volar unfavorable defects. If the defect is slightly volar unfavorable, I may choose to shorten the fingertip and lengthen the nail to avoid doing a cross-finger flap or reverse vascular island flap, because this flap gives good sensation, low complication rate, and has good outcomes. Thank you.
Thank you, Dr. Gun. Any questions? Okay. That was a very nice presentation. Thank you. Now I invite Dr. Pankaj Sir, Senior Consultant, to talk about his innovative method, flip flap for fingertip injury.
Good afternoon. Thank you very much for being in the auditorium. We'll talk about a new way of restoring the distal part of a finger. Can I have the slide, please? So it's an osteocutaneous flap harvested from the middle phalanx to restore the distal phalanx. And the problem is, it creates a psychological wreck for most of the patients, especially in this part of the world where the marriage is an issue. Their marriage market goes down significantly, at least in this part of the world. They keep gazing at the fingertip, which is amputated, and do not concentrate either on studies or work. And the options that are available is external fixation for lengthening or toe transfer with lengthening. So what we are doing is a schematic representation. A distal phalanx is missing. So this is the volar part. This is FDS tendon. We osteotomize the distal part of the middle phalanx in the coronal plane, and the volar half of the cortex with the overlying skin is reflected distally. And the defect so created is covered with a cross-finger flap. So this is, again, a volar skin with the volar cortex of the middle phalanx is osteotomized with the volar skin, and the defect is covered with a split thickness skin graft and fixed in about 10 degrees of flexion. And this is hinged on the dorsal skin. So the first example, this 26-year-old male had a fingertip injury 6 months earlier, and this is how he presented to us. What he did, a volar skin of the middle phalanx with the volar cortex of the middle phalanx was reflected distally. They were taken together. Skin is slightly longer because we need to know how much we are dissecting and we need something to purchase. And they were reflected distally, and the defect so created after fixation with two K wires was covered with a cross finger flap and anchored with two wires, and the DIP, so-called DIP joint, is fixed in slight flexion, and this is just before cross finger flap division. This is after 2 months, and we have a lengthening of about 11 millimeters. This after 8 months, we see some joint line, but there is no abnormal mobility, there is no tenderness, this is fibrous union, delayed union, whatever, but there is no pain, and he is using his computer operation extremely well with the affected finger. And this is where we began with a shortening, and this after lengthening of the finger and primary healing, no infection. This is the dorsal and this is the volar aspect, and the finger is almost at least equal to the one of the fingers. This is the range of motion of the PIP joint. The lighter color of the volar skin, which now comes to lie on the dorsum, mimics a nail, and this is what the observation of the patient. I didn't even realize this. So they are happy patients at this. There's some deviation to one side. This is maybe because of the poor hold of the K wire, or maybe because of the deviation because of the traction exerted by the adjacent cross finger flap. Next patient, 26-year-old female, farming injury, amputation through the distal interphalangeal joint, presented with this kind of a defect. Cross finger flap, lengthening. This is the amount of length we achieved by reflecting the volar skin and the volar half of the middle phalanx. This was a full thickness skin graft on this side. This is just before division, and this is the kind of lengthening we achieved. Again, about 11 millimeters was harvested. Appreciate this new bone has formed. This about 2.5 years post surgery. We have about this has hypertrophied, lengthening of about 11 millimeters here. Again, some deviation, lengthening. Again, appreciate the lighter color, and therefore again to the patient it appears nail-like. It is not a nail, but looks, because of the lighter color, nail-like. To a person who's looking at it, doesn't even realize the finger had an amputation. And PIP joint has a good flexibility. There's a lengthening, there's no bone absorption, there's no bone sclerosis suggesting the bone is dead, and there's a trabecular formation again suggesting the bone is live. This is the lengthening that we have been able to achieve. Literature search, I found one French article where the lateral half of the cortex of the middle phalanx was reflected to create in the acute situation. And that was a case study that I came across, and based on one of the arteries coming from the digital artery. How much bone can be reflected? Anything that is distal to FDS can be harvested. How much? You have to go about 8 or 9 millimeters distal to the volar crease, and that's the amount of bone you have to save to prevent injury to the FDS tendon. Refinement, yes, we need refinement because we don't want this angulation. If you put a plate on the volar aspect, probably we'll have the plate will be palpable. Therefore, maybe adding a couple of wires may be helpful. Shaving of the cartilage may help. Probably this is of course I won't say this is a pseudo arthrosis, but probably the joint line at least will not be visible. I can harvest a little bit of bony spicules from here and graft here. More length can be gained because this amount of bone, which is about 8 millimeters, can be harvested. I need to save only about 9 millimeters of FDS here. So some more length can be reflected. How much skin? I do not know how much skin can be taken because the current literature is only about the uninjured finger. How much skin can be harvested from an injured finger? I have no idea. How soon after trauma? This remains a question. Can the phalanx, when it is being osteotomized, splinter? Yes, that's a distinct possibility. Well, I'll treat it like a comminuted fracture. What about the skin if it turns ischemic? I am reflecting. Yes, again, that's a distinct possibility. Maybe I'll put it back, delay it, or put a thinner flap. It remains to be seen. What is the future of this method of restoration of distal phalanx? Time will tell whether it is better than external fixator or it is better than toe transfer. But toe transfer itself has a significant donor site morbidity which may not be often acceptable to the patient, or whether peg bone grafting. 2 cases have presented and given an extremely great results. So in summary, distal reflection of the split middle phalanx with a cross finger flap is a viable option. It opens up various possibilities in congenital and metacarpal loss as well. I thank you very much. If there's a similar paper somewhere, I would like to know myself. Thank you very much. Any questions, comments, criticism, please? And both the candidates, by the way, are open now in the marriage market. They are extremely happy. Wow, we are going to get married now.
Thank you, sir.
Thank you very much.
Excellent presentation. I thank all the speakers. Thank you very much.
Thank you to our